Good evening to the Sampler Society AERD support group. It is my pleasure to be here this evening. I'm Dr. John Basso. I'm the medical director of the University of Pennsylvania AERD Center, and I am a clinical associate professor at the Perlman School of Medicine, University of Pennsylvania. And tonight we're very happy to be here on the behalf of AERD Awareness Day. This is our first AERD Awareness Day, and it's exciting, wearing our t-shirts, and we are prepared to answer some common questions for you this evening. My partner, Dr. Adapa, if you introduce yourself.
Sure. My name is Nathan Adapa. I'm an associate professor here at the University of Pennsylvania in the Division of Rhinology and Skull-Based Surgery. I'm also the fellowship director here and the surgical director for the AERD Center. So hopefully what we'll be able to give today is an informative look at both the medical side and the surgical side that makes us so successful in management of AERD disease.
What's unique about our center at Penn is that we're multidisciplinary. And so we realize that this is a difficult disease, it's a complicated disease, and it really does take a team to really manage this optimally. And I think that's where we excel, is that we have a lot of great communication, and it's smooth, and patients are seen often and discussed on the same day. And so there's a lot of seamless coordination that occurs, and this is what I think has made us very successful. To start with, our first group of questions is going to deal with the symptoms of AERD. And I think everyone is familiar with the symptoms of AERD, which, as you know, are primarily rhinitis and rhinosinusitis, which are nasal congestion, recurrent sinus congestion, sinus infections, runny nose, loss of sense of smell, nasal blockage, and then chest symptoms of cough, wheezing, shortness of breath, and of course the hallmark is the respiratory reactions that occur to aspirin and non-steroidal anti-inflammatory drugs. So of course this disease, the problem with it, as we all know, is because it's complicated, there's often a long lag time before patients are diagnosed. So first we'll take some questions that are symptom related, and we have a list of them here. The first one is, why does AERD cause fatigue, and is there any research being done on this? This is a great question. We probably don't know the complete answer. My best assumption here is based on the literature and what we know about sleep-disordered breathing. All these patients have nasal blockage. They don't breathe well through their nose, and so this is probably a factor. And the other thing we know is that any chronic inflammatory disease that patients have often leads to fatigue. So when your body's fighting an inflammatory process, that will take its toll as well. Is there any research being done on this? Well, we actually have been stimulated to talk to our sleep apnea colleagues here at Penn. We have a group headed by some of the prominent sleep apnea people in ENT, and we're going to probably be looking at this in a little more detail, which leads into the next question.
So the next question here is by Mary Lou. Can AERD cause sleep apnea? So that's another great question, and truth be told, regarding obstructive sleep apnea, we think it's multifactorial in etiology. Any cause of nasal obstruction is likely contributing to this. But regarding actually causing sleep apnea, I think it's it's likely multifactorial in etiology. What we know when you look at this is you look at treating AERD, would that treat sleep apnea itself as a cause itself? And so far the literature has not been great on any nasal obstruction actually fixing sleep apnea. So there's been one small study out of a Turkish group looking at AERD that did show some success, but in general, when we look at the larger studies, most of those have shown, if you look at actual sleep apnea scores, which are your AHI index, most of these obstructive nasal diseases, including AERD with obviously nasal polyps or other chronic sinusitis with or without nasal polyps, they're not doing a whole lot to really decrease that AHI number. They reduce them a little bit, but don't really fix sleep apnea, so that would imply this is likely not the cause of it. That said, there are a lot of other studies that look at quality of sleep. So you're not actually looking at this strict AHI number, but instead asking patients, if you're treated for AERD effectively, do you feel that your sleep has improved? And most patients, again, with nasal polyps have shown that they are improving. We're actively looking at our AERD population, but we think that'll be the case as well.
Yeah, and to add to that, there are some studies suggesting that the scores that patients give us on the quality of life assessments for sleep are improved after they've had a good surgery and aspirin desensitization. So that's good. But again, a lot more needs to be looked at with that question. I forgot to mention, Eddie asked the first question on the fatigue. Candace asked, can female hormonal changes impact AERD symptoms? So again, this hasn't been that well studied. Observationally, I would say that hormones likely play a role in this disease, and the reason I say that is that premenopausal patients seem to be a little bit more difficult to manage. They're usually a little bit more of a challenge. They may have more aggressive disease. Again, that's not a blanket statement, but on the whole. And the other thing that we've noticed is that when most patients go through a pregnancy, during that pregnancy time, the symptoms seem to be more quiescent, only to rebound 6 or 8 weeks after delivery. So we know that hormones play a role. It's not so easy to study that. We're looking at some data trying to corroborate the premenopausal versus the postmenopausal. I think that that is definitely what we've always felt, but I think we don't have a lot of data.
So let's look at another question.
Next question.
You got one, or you want me to go?
Yeah, they'll just. Can AERD cause chronic hives and rashes? Yes, the answer is yes. There is a small subset of AERD patients who get chronic hives as part of their condition.
All right.
That was it.
For me?
Yep. Mm-hmm.
All right. Is loss of sense of smell with AERD temporary or permanent? That's a great question. That's a question I get asked just about every AERD patient I evaluate. As those of you who have AERD know, that loss of sense of smell is one of the key hallmarks of the disease process. From our understanding, there's essentially 2 aspects to the anosmia or smell loss you have. One is, currently the polyps are if you have polyps, they're obstructing the olfactory cleft, and that's where our smell nerves are. So you literally have a mechanical obstruction of these odorants getting to where they need to be. The second part, and that's the part that if the nerves are functioning fine and surgery is successful with successful post-surgical treatment, and we have the reduction of polyps and nice, clean, healthy cavity, the sense of smell will return. The other problem, unfortunately, though, is we do know over time of having this inflammatory process, your top-end function of your smell reduces. What is unclear right now, we're actually actively studying this with our neurology group, is whether this has to do with the actual smell nerves in that olfactory groove up in the ethmoid cavity, whether those are non-functioning there, or another hypothesis is the actual brain pathways, because they're not being used frequently, are shutting down, and we're looking at this actively. But between the 2 of them, there is a chance, even after surgery, that you don't have a sense of smell return if you've had this inflammatory process going on long enough. Most from my end of things, when I ask patients, is if I had given you a burst of steroids, or someone's given you a burst of steroids recently, do you get some sense of smell back? If the answer is yes, generally speaking, I'm pretty comfortable saying we'll be able to get that sense of smell back, and hopefully a little bit better than that. But if they tell me, no, a lot of my other symptoms resolve, but I still get no sense of smell back, it's of lower likelihood that you're going to get that smell return. Another question we were asked by Mallory, can AERD lead to dental problems due to mouth breathing and dry mouth?
Yeah, you take that one.
Sure. So absolutely. So the data has been pretty clear. Anybody who is a chronic mouth breather has increased risk for dental cavities, dental bleeding, etc. Essentially, with the drying of the mouth that they're suffering from, bacteria are able to build up in this area more easily. So it's not specific to AERD, but it's specific to any problem that causes nasal obstruction and causing you to breathe through your mouth.
Okay.
Switch over to diseases.
So the next set of questions is related to the disease itself, causes and mechanisms of AERD. The first question comes from Georgia. Are there any studies in progress to determine the cause of AERD? Well, the answer is yes, and there are a number of labs, including ours, that are looking at the causes of AERD. I believe that it's probably going to be a multifactorial, not a single cause disease. So I don't think it's going to be as easy as we think, finding a specific cause. What we do is all the tissue that's taken from surgery is now being looked at. We're doing DNA probes. We're looking to see if there are certain viruses or other organisms, fungi, bacteria, that may be playing a role, and then we can detect those at the DNA level. So we are looking at that, and it is, I think, a very complex multifactorial disease, and I believe when we get all the data in, it's not going to be just this specific cause. But again, this is definitely the holy grail of what we're looking for, and I think that there'll be more studies on that in the future. The next question was asked by numerous people, and the question is AERD inherited, and will patients pass it on to their children?
That's a great question.
That's a great question. And you know, everyone should know. The answer is no, at least from what we know, and I can vouch for it clinically, but the studies are very clear. There doesn't seem to be one specific gene that's transmitted from one generation to the next. We really believe that environmental factors, be them viruses, toxins, pollutants, bacteria, fungi, we believe those are most likely what brings on a change in the lining of the sinuses, the epithelial lining of the sinuses, to start the disease process. Nothing about genetics, all the studies on genetics have not led to a specific end. There always seemed to be no follow-through, because no one's ever really found a specific gene. And so the answer is no. And the next question is, are there any other diseases or disorders that seem to be more common in patients with AERD? Well, the answer is no to that as well. AERD is not felt to be an autoimmune disease. At least we haven't discovered that it is. We haven't found an antibody that is present that's attacking tissue. And so autoimmune diseases can sometimes be associated with other autoimmune diseases. It seems to be more of an immune dysregulation that's started by some environmental exposure. But there, at least at this point, there do not seem to be any disease associations. As much as you may think, well, I have this condition and I have AERD, isn't there an association? At this point in time, we have nothing to specifically tell you on that, and so I'm going to say no, but leave the door open for potential future studies that may show correlations. I have not seen it clinically. I have not seen a repetitive disease that seems more common in patients who have AERD, and so that's the answer to that question. Next question's a good one, and it has to do more with AERD awareness. AERD is unfamiliar to many doctors who are not specialists. How can patients best explain aspirin desensitization to these doctors? Well, if you are a reader of the medical literature, last week there was an article in a widely read medical journal, the New England Journal of Medicine, that all general physicians seem to subscribe to, or all they should subscribe to. So the word is getting out there a little bit more, and I think the best way to do it is to bring your physician medical literature. And it doesn't have to be last week's New England Journal article, which was a good one for explaining the disease process. And often there's, when it makes it to the New England Journal of Medicine, it often gives validation and maybe other doctors take notice. So I think it's really good that it did get to that level. But there are many, many, many articles out there from many other prestigious journals that are reviews of the disease. And I think that would be the most helpful, because that's what as a physician, if someone told me about a disease I had never heard of, and they brought me an article about it, I know I'd read that article and I'd learn about that condition. So I think most physicians still want to learn. And there's nothing like handing a physician an article or giving them a reference or a link or something like that to the article.
And I will add there, for it was Christine P. who asked that question, there are a lot of specialists who aren't that aware of the disease entity as well.
Yeah, well, absolutely.
And we've seen that as well as giving talks around. A lot of this awareness is not just to the general practitioners, but also specialists, both to understand not just nasal polyps, because we all know nasal polyps, but that this is a complete subset, or what we call in the medical term an endotype, a completely different set of patients with nasal polyps with AERD. So we're also, this is why today is very important, AERD Awareness Day, is so we can get the word out of this disease process that affects a good number of people across the country.
So
right?
well said, yeah, and we still are having trouble getting it trickling down from specialists. Generalists are, are even more in the dark, but again, it's important to spread the word, absolutely. Right, we got our t-shirts
absolutely.
on. Our whole department that is involved with the AERD Center today took a picture with the AERD t-shirts on. Our t-shirts came right after lunch today. We were very fortunate that they got here on time. Just cutting it very close. So, I mean, we were really worried. All right, what else is on the list? Could getting liquid ibuprofen on the skin cause an AERD reaction? Rachel. Well, theoretically, yes, but unlikely. I mean, you'd have to get a significant amount of it absorbed into your bloodstream. So you'd have to get a lot of it on your skin, and it'd have to be absorbed for a while. With that said, there is a compound, diclofenac, also known as Voltaren gel, which some people rub on sore joints, and that's an NSAID. And enough of that does get absorbed into the body to potentially cause a reaction. Even eye drops that contain NSAIDs, ketorolac is an eye drop, has been reported to cause asthma in patients who have AERD, asthmatic reactions. So anything that gets absorbed into the bloodstream would be a potential. I think the dose in the bloodstream would have to be of a threshold to trigger an attack, but you never really know how much is getting absorbed with these topical products. And a lot depends on what percent gets into your bloodstream and what level gets into your blood and how sensitive you are, because people react at different doses depending on various factors. So that ends the disease-specific questions. The next group of questions is related to treatment and treatment plan. And the first one comes from John, who asks a question that maybe we'll get into a little more detail on, which is, what is the current evidence-based program for those with chronic severe symptoms, and in what order should these interventions occur?
Great question.
So yeah, it's a great question, and it's going to require, I think, both of us to talk about this. Our coordinated approach usually involves starting with a complete sinus clean out. So surgery first, and then usually about anywhere from 4 to 8 weeks post-operatively is when we'll institute aspirin desensitization. We of course use topical corticosteroids in the sinuses as an adjunct therapy, and we also use leukotriene modifiers in most cases. And so these are, and maybe it's possible in the future for refractory cases we could start using biologics. I'll talk about those a little bit more at a later question. Nitin, you should start talking about the sinus surgery and how that gets, phase one basically of our treatment.
So one of the questions we got asked is, why do some sinus surgeries succeed and some fail for AERD? So there's a few, it's a little bit of a longer broad-based question, but it gets into a little bit of our philosophy and how we're gonna succeed with AERD. Basically, when sinus surgery first started, our thought process was opening up the sinuses to allow drainage of these sinus outflow tracts. And that works for a lot of patients with different sinus problems. Unfortunately, AERD, if you think of it from an inflammation standpoint, these patients are at the most severe inflammatory form, so simply getting drainage out is just not good enough because you still have that inflammatory load in the sinus cavity and you're not getting penetration for any other treatment in there. So one, it is to open up and allow for drainage, that's accurate. But the two other differences is the other thing you really need to do from a surgical standpoint is get every little bony partition in the sinus removed. So the sinus cavity has a number of bony partitions that we don't truly know exactly what their function was there. We think it's some sort of immune mechanism, somewhat like if you think about your adenoids and your tonsils at some point. And now they're really not serving any function except in patients with the AERD, they're a nidus for inflammatory disease. So this tissue really has to be removed from that sinus cavity. So you're minimizing your surface area for polyp recurrence. And then the third thing you really want to focus on is cleaning out every last little bit of the sinuses. And that means not just your maxillary ethmoids, but you need to go all the way up, clean off those ethmoid cavities all the way up to your skull base where those smell nerves are, in your frontal sinus or in your sphenoid sinus, so that the next step from a medical standpoint can be that we can get topical steroids into the nose. So when you see a lot of ear, nose, and throat doctors pushing the neti pot and rinses and topical steroids, they still need to get where they need to get. So if the surgery has not opened up all those cavities, it's not going to be very effective. And so that's from a surgical standpoint where we see some failure if that component has not been successful, and that may be successful in many other patients. Just in our series in the AERD patients, you really need that clean out. And then the next part that we'll flip back to John here is you need to have appropriate medical therapy. Again, sinusitis in any form is not a surgical condition. Ultimately, it's a medical condition. What we're doing that sinus surgery for is to remove the inflammatory load, but also get topical rinses with steroids in there, and then ultimately move to the next step, which is the long-term medical therapy. And if you don't get that medical therapy in a timely fashion, again, you're going to fail from a long-term treatment algorithm. So both components really need to be optimized with patients with AERD. It's just such a severe disease process from a sinusitis standpoint that you've got to be very coordinated.
Yeah, and we all know that we will get benefit from oral corticosteroids with this disease, but our focus is to try to ultimately reduce the need for them because of their long-term side effect profile. So if they didn't have any side effects, we'd use them a lot more. But we use them appropriately, post-operatively, of course, because you get some inflammation just from the surgery itself, but also because you need to have all that post-op, I guess, mucus and inflammatory tissue. So it's effective to do it post-operatively, but the ultimate goal with your topical steroids and then doing aspirin desensitization needs to be done in a timely manner. So depending on how well the patient heals, in our department, usually we don't do it any sooner than 4 weeks because in the first 4 weeks they're on enough oral steroid and they're also getting a lot of post-op debridements where you're pulling out
they just have not
completely healed, right. And then somewhere between 4 weeks and usually no later than 8 weeks is when we bring in what is the most effective, and there have been the most studies on aspirin desensitization and long-term aspirin therapy. And that still remains the gold standard for the treatment for most patients. I'm not saying it's for all patients, but for most patients, that is the most effective way to reduce the need for corticosteroids, slow down polyp regrowth, and basically get better control of the disease, improve sense of smell, and improve the anti-inflammatory therapy. What aspirin therapy does is it reduces a number of inflammatory mediators that are causing that swelling and inflammation. Because it has an effect on so many different mediators, it's much more effective than just blocking one, like a leukotriene, or like a biologic, just blocking one interleukin 5 or interleukin 4. So although they often are necessary adjuncts in very severe cases, and again, we'll do everything possible to spare the long-term use of oral corticosteroids. The one treatment that has the greatest effect is aspirin therapy.
And John, if you don't mind me asking or jumping in, I think it's important for the audience to know that that timing of when the desensitization is really important. So if a significant amount of time has gone by and patients start getting polyp regrowth, and correct me here, John, but aspirin desensitization does not shrink polyps down.
No,
So you need to have those polyps completely clear, and that's where that critical surgery comes in.
and you don't have a lot, right, you don't have a lot of time to really, I mean, inflammation doesn't take a holiday, right, Nathan? So you really have to get in there just after surgery, as soon as the healing occurs, because the more time goes by that the clock is ticking, the polyps are regrowing, and aspirin prevents the growth of new disease, but it really doesn't get rid of what's already established. So the time to do it is when you have a blank, clear slate. You basically, just like rebooting your computer, you're getting a second chance, everything is perfectly clear. We know that's a temporary state of affairs, but that's the window of time to get in there and do your medical therapy and your aspirin desensitization. Okay. Is aspirin desensitization recommended for patients who have not had polyp regrowth following surgery? And can it help with asthma control? So part one of and this is Christine. So part one is it's very unusual for an AERD patient not to have polyp regrowth. I think if you've gone a year without polyp regrowth and you're not on oral corticosteroids and you're not on any other therapies, maybe just topical steroids, then you have a very mild case of AERD, and that's great. And if you are that mild on the spectrum, then you probably don't need aspirin desensitization or anything else. So consider yourself, even though it's it's somewhat difficult to have this condition, but on the spectrum, that would be the milder version. And so the answer is, yeah, I mean, if that exists, and we don't see a lot of those patients because we're often seeing the worst of the worst. But over the years, I've seen a few of those, and yeah, and when that happens, we don't do more than we need to do. Can it help with asthma control? The answer is yes. It's been shown in the Scripps Clinic study. It showed that there was a reduction in asthma exacerbations, and indirectly, because this condition is really the type where if the sinuses are clear, the asthma is easier to control, and when the sinuses are a mess, the asthma is difficult to control. So it's really a secondary effect, but you do get better asthma control. Is there a protocol that can be used to desensitize patients who initially failed desensitization due to persistent worsening symptoms? Eileen asked this question. Very good question. Fortunately, that's a very small percentage, perhaps 5% of patients who can't seem to maintain a desensitization after you've done the first 2 days and they seem to be persistently worsening. Fortunately, we don't see this very often, but when we do, there's not a specific protocol that we've come up with, but there are a few tricks that I've learned over the years that seem to be effective, at least anecdotally. Some of them include using anti-IgE monoclonal antibody omalizumab known as Xolair. That's been one. I've had some success in a few cases where patients have gone on that treatment to reduce the output of some of the mediators that are just produced in such large amounts. But the other reason why it doesn't happen too much, I think, to us is two reasons why we don't see it as often, the worsening, is one is Nithin and Dr. Dappa and Dr. Palmer and Dr. Kennedy and Dr. Kohansky, who are our sinus surgeons, do such great surgery to begin with. And I make sure that your asthma is under certain perfect control before going into the therapy, the desensitization. So by having that pre-desensitization period being where the patient is at their absolute best, that does minimize the chances that you're going to worsen afterwards. That being said, there's still going to be a very small subgroup that'll either be intolerant of aspirin desensitization. We recently had a patient who had chronic hives which worsened after the desensitization. The sinuses and the asthma are doing well, but the hives were so severe, and this was about 5 years ago, and the patient was put on omalizumab Xolair for chronic hives about 2 or 3 years ago, came back to see me again and said, "You think we can try aspirin again now that I'm on Xolair and I've had no hives for 2 years?" And the answer is, I said, yeah, now I think you're in a position where we can try it again. And so it was successful. Again, we have these anecdotes, but I think we're going to put them together and start a case series. So yeah, the answer is not any specific protocol, but certainly we look to try to get these people as well controlled and perhaps on as many medications as possible to see if the aspirin will be successful. Carolyn asks, are there any special concerns about managing AERD in the elderly patients? Well, in elderly patients, first of all, I've learned that the dosing of aspirin usually has to be lower than in the average middle-aged or younger patient. They certainly may be at slightly higher risk for bleeding complications and also for bruising. And I also find that as you get to be elderly with this disease, it seems to require less aspirin to keep the disease under control. So perhaps there's some burning out of the inflammation and the T cells and the inflammatory process as one gets older. That I think has been reported. And so I usually go a little bit more ginger on my older patients with all medications, not just aspirin. The next question is, are biological medications as successful at treating sinus symptoms as aspirin desensitization? Well, we don't know the answer to that question. I mean, certainly there haven't been any head-to-head studies. My answer to you at this point is, based on the available evidence, no. And I believe it's because aspirin desensitization blocks multiple mediators, not just one mediator. That's number one. Number two, I think that you have to think about the process of how many patients have really been treated. And there really are only two studies showing, one for omalizumab, Xolair, and one for Nucala, which is mepolizumab, that have shown some reduction in symptomatology in AERD patients. I find that anecdotally, the asthma seems to improve much more robustly than the sinuses do in AERD patients with biologics. Time will tell. I think we'll need more data and more studies, but certainly we need better controlled studies, and there are so many more studies showing that are controlled that show the effectiveness of aspirin. And again, with the multi-mediator reduction, I think this is where the advantage is, and this is why we get more success. Will I use them as adjunct therapy? The answer is yes. Do I think they, especially in patients who aren't responding to the usual protocol? So again, time will tell where they fit in the treatment paradigm, but I do think that they will be used here and there in our patients in the future.
Let me take the next one here. How long after FAST, so that's sinus surgery, can patients expect a full recovery? What symptoms are a normal part of the recovery process? So I tell most of my patients, I tell them that it's going to be a couple days that you are a bit down for the count, usually about a week that your symptoms are definitely worse than they were actually before surgery. And then after about a week, that's when things start to really turn the corner. And I typically tell my patients it takes about 3 to 4 weeks till you're fully recovered. During that recovery period, I joke with my patients by saying all the symptoms you had during all the sinus inflammation, you'll continue to have for that first month. So that includes the nasal congestion initially. You'll have anosmia for at least 2 weeks, up to 4 weeks if it's going to recover. And we talked about that issue about the loss of smell. Postnasal drip and drainage takes a long time to settle down, just because just the healing sinuses create lots and lots of mucus, and that drains down the back of your throat. And these type of symptoms are going to be there for at least about a month, but it's a slow and steady recovery. Another great question by Kelly. How beneficial are steroid implants for AERD patients? So going back to our treatment algorithm, you have to think about what are your goals. So if your goals are, hey, for whatever reason, my sinus have flared up, I've got polyps there, I need some immediate recovery, steroid bursts are going to help that, which again have the systemic side effects, or Propel is going to help that in a short period of time, one of these type of steroid implants. Steroid washes are going to help that, but these are all short-term treatment options. For somebody, again, I think we've been stressing this AERD, which is such a severe disease process, none of these are going to give you any long-term treatment. Now, there are certain situations where I see a patient who has had very good sinus surgery, like say a year ago or so, so they've had that clean out cavity we talked about, but unfortunately have had some polyp regrowth. Before we send them over to Dr. Basso for desensitization, he really wants, as we discussed, to get all those polyps removed. So that may mean surgery, but in certain situations, that may mean either putting a Propel stent in, or giving them some Pulmicort, or in a little more severe situations, giving them some oral steroids to settle that down. So I don't want to imply that we always need a surgery before the desensitization. we always need that clean cavity before the desensitization. So if you've had surgery sometime in the past, it may be something that we can recover from in a non-surgical manner, but this is one of those we really have to see both endoscopically and typically on a CAT scan the amount of disease process there is.
You want to take the ear question?
Sure. Will treatments like aspirin desensitization or biologic medications help with any of the ear otologic symptoms in patients that patients can develop? So there's a number of different ear issues. The most common thing people typically refer to as eustachian tube dysfunction. The eustachian tube is essentially the tube that connects the middle ear to the back of the nose or the nasopharynx. And that's a tube when we go in an airplane or fly and we yawn and you hear the ear popping, that's that tube that's equalizing the pressure. Unfortunately, people with any sinonasal issues, from anything from allergic rhinitis to, again, severe forms of sinusitis like AERD, can develop dysfunction of this tube. Both the sinus surgery and the desensitization or anything that reduces inflammation typically helps the process. I tell my patients that you can't expect anything perfect from that standpoint, so it's one of those that we hope that it improves for you, but it's one I say, I'm not going to give you any guarantees on the ear because you never know how it's going to respond. So we're looking at this closely as far as specific to the AERD patients, but it's one of those that in general, anecdotally, we've noted with the severe polyp patients that improves it to some degree, but never makes it perfect.
We also get patients who have fluid in their ears. That we've seen that, and we've even seen patients have polyps in their ears.
Yeah.
So that's a difficult issue. Our colleagues here in the ear section, the otology section, are very interested in studying this, and we're going to look to see whether treatments for AERD, how much they have an effect on the ear symptoms. One of the people in the department is very, very interested in doing this, and so we will be reporting on that hopefully in the next couple of years. I think the last question is, does a low salicylate diet have any benefit? And the simple one-word answer for this is no. So don't do it. Don't go on a low salicylate diet. I know there's a lot of anecdotal literature out there, and there are a lot of people advocating for it. First of all, we know that salicylates in food do not activate the same mechanism of inhibition of the enzymes that aspirin and non-steroidal anti-inflammatories do. So it'd be really difficult to see how any mechanism would occur in that and to benefit patients with this. It's also a very difficult diet. I think some of the reason why some of the success has been reported with this low salicylate diet is because it involves taking alcohol out of your diet. And we all know that 80% of AERD patients have an intolerance to alcohol, particularly red wine and beer. And so when you take those out of the diet as part of a low salicylate diet, you improve. But it's not because of taking salicylates out of your diet, it's because we know alcohol itself and some of the polyphenols in alcohol can actually trigger the inflammatory cells to release mediators. And that's why you feel miserable when you drink alcohol if you have AERD. And just to remind you, I think you all know about the study that we recently published that I'm very proud of, and that is that patients who are desensitized to aspirin have a great increase in their tolerance. 86% of them reported a significant increase in their alcohol tolerance. Another good reason to have aspirin desensitization, right? We have some on the fly, I guess, some questions that we did not see before. And so,
You want to go first?
why does alcohol, I answered the first one, why does alcohol cause AERD reactions? Again,
Susan, perfect
person questions. There are polyphenols or catechins, chemicals in alcohol that seem to directly trigger mast cells and basophils to release their mediators and then cause respiratory symptoms, mostly nasal and bronchial type symptoms. We don't know, and of course, therefore, aspirin desensitization by reducing those mediators probably helps from that. Effect. Okay.
You want to go or you want me to go for one?
I'm not sure I understand this question.
Plaque, coronary artery disease?
It says, is plaque buildup a symptom related to AERD? I'm assuming you mean plaque in the coronary arteries, right? The answer is not to, and I've never seen a study showing that, or nor have I, to the best of my knowledge at this point, what we know, the answer is no. In fact, being on aspirin, as you know, prevents coronary thrombosis. So it has the cardiovascular benefit. So do you have to be off aspirin for a certain length of time to get re-desensitized? So the refractory period, that's the period of time where if you miss taking aspirin, is a minimum of, it's somewhere between 2 and 3 days, and no more than 5 days. So we strictly instruct our patients not to miss their aspirin for more than 48 hours. Probably 72 hours is the time where you start having some reactions, and at 5 days, everyone is completely lost any vestiges of improvement that they have gained from being on aspirin. So unfortunately, it requires repetitive dosing in order to maintain the benefit. I think that answers that question, right? Are there more?
Yeah, there's a couple more.
That one's definitely for you.
Is sinuplasty an effective treatment? What do you think, Abby?
Balloon, I mean balloon
So we're talking, I think,
sinuplasty.
balloon dilatation. So if, Abby, if you heard what I said earlier about the goals of what we're trying to do for AERD, I think balloon sinuplasty has a role in sinus disease. So in certain patients who have certain obstructive sinuses, it's enough to open those sinuses up, allow some drainage, allow that inflammation to decrease. But for AERD patients where we're saying the goal is to get all those polyps out, to reduce that inflammation so then the desensitization can be effective, the sinuplasty itself is unfortunately not going to accomplish that. So it's really, again, for us, if you think about it, we're trying to reduce that inflammatory load, and just opening up the sinuses alone is just not going to get that done. So for AERD, and again, I want to say sinuplasty has a role in sinus surgery, but for AERD, it typically is not going to be very effective. And then here's a question for Michelle.
And it's a diffuse inflammatory disease, so if you're just going to one little
Right.
area of drainage, you're really not going to get it. And this is, we have time for one more.
This
This
is
is the
great.
final question.
All right, final question. This is another great one. Michelle, what do you think of the polyp vac procedure? So the polyp vac, again, so for those of you who don't know, polyp vac essentially, you're in the office and you have an instrument that we actually use in the operating room called a microdebrider, which essentially goes in and sucks a polyp and cuts a polyp and suctions it away and removes the polyps in the nose. So the polyp vac is a specific company that makes this device for the office itself. So if you go back to, again, what we said with Abby is, if all the partitions have been removed in a prior surgery and everything's been nice and open, and you can then take the polyp vac in the office and clean out all those polyps right at the skull base, works fine. In fact, we've had a few patients I had patients who kind of fell off the wagon doing their rinses and had some polyp recurrence and initially held off in the desensitization. I polyp vac to clean them out.
Right.
You desensitize them, they're doing great. So if all those partitions are gone, I think it works great. Now, if you're talking about you've got a lot of these partitions left, you've got just big polyps blocking your nasal airway, they'll give you some breathing relief, the polyp vac, so you'll say I'm breathing better, but you'll still have a lot of disease up high, and then the desensitization is not as effective again. That was a great question.
Absolutely, that's a great question, and you know it's nice when that can be used as opposed to having to go back to the OR. But there's really a limited number of situations where you can use it, but I've seen it be very effective.
Great.
Okay, well, I think we're going to have to conclude, but hopefully the audience got some good information from my partner and myself about the surgical and medical aspects of AERD. We are very happy to be participating in the first AERD Awareness Day, and hopefully this will be every year to come, and the number of people involved will be growing and growing. And so thank you, Andrea Reinhardt, for putting this together. Andrea really is really a barrel full of energy. She's really a dynamo when it comes to putting all this together, and she is really to be applauded for her efforts for putting this together. And
Absolutely.
all right.
Thank you.
Thank
Take
you
care.
very much. Good night.